For people with spastic diplegia, the simple task of sit to stand is suddenly not so simple. The muscles that are typically spastic in these individuals are hip adductors, hamstrings, and plantar flexors. As we move through the phases of sit to stand, you will see how these spasticities influence their standing technique. In the flexion momentum phase, the patient requires multiple forward leans with exaggerated upper extremity involvement as the patient depends on forward momentum to stand as opposed to lower extremity strength. The patient's sitting posture is noted by hip adduction spasticity that causes a knock-kneed position. Additionally, they have their ankles in a plantar flex and inverted position. During momentum transfer, the patient breaks their knees together to help raise their bottom up. There is increased anterolateral trunk flexion and the use of upper extremities to help stand. This is a quick phase for these patients as they depend on momentum. Oftentimes, there is trunk rotation to help with weight shift and momentum to ease the task of standing. In the extension phase, the patient does not reach a fully erect position. They maintain slight anterior trunk flexion due to spasticity and to keep their center of mass over their base of support. Their knees stay in a flexed position while their ankles are plantar flexed. The patient continues to utilize trunk rotation to stand. Hip adductor spasticity causes the knock-kneed position throughout this phase. For the stabilization phase, the patient stands in a crouched position with the knees flexed and the hips adducted. The patient displays a narrow base of support with the ankles plantar flexed and inverted. Patient continues to utilize an anterior trunk lean to increase their balance. For the task of sit to stand, we identified hip adductor spasticity as the major impairment. We conducted our treatments in a manner that appears to a child, but the basic exercises could be applied to any population. The first treatment is squats with a bolster between their legs. This prevents the patient from adducting when they stand. For the pediatric patient, once they stand, they get to blow a toy windmill. The therapist stands behind the patient to provide support if needed. The patient's mom is involved by holding the toy. This next treatment is a lateral step with a squat. The lateral step is working to strengthen the hip abductors. The squat adds a strengthening and stretching component. The therapist provides manual resistance to hip adduction as the patient squats. The patient's mom is involved by holding a puzzle board for the patient to place pieces in that they pick up off the stool. Both of these treatments work in a whole task fashion, which research has shown to be more beneficial.